just in case you wondered. Dr. Soh is one of our distinguished CAP fellows, Child and Adolescent Psychiatry fellows. I was fortunate enough to work with Dr. Soh in the Child and Adolescent Mood Disorders program. He is a graduate of UCLA, bachelor's in 2009, did his MD at UC Irvine, his residency in adult psychiatry at Harvard, and then of course joined us for the CAP fellowship starting in 2019. And he has a fairly interesting background, I have to say. Some of this surprised me. He started out in cancer research at David Geffen and at the VA. In fact, has a very distinguished publication in suppressing tumor cell growth with cystatin that appeared in Molecular and Cell Biology, who was first authorship, and received a scholarship for his cancer research. He's worked at the Koreatown Youth Community Mental Health Center, has done quite a bit of community outreach actually, and impressively co-founded an organization called Masahi, the Mount Elgin Social and Health Initiative in Kenya. And believe it or not, he was able to treat with his colleagues over 1,200 individuals per visit with his Kenyan doctors and the pharmacies and nurses he was working with. We complain about, a half dozen patients in a day, and they treated 1,200 per visit. This was a war-torn area. He arranged to have aid sent to displacement camps, educated the community about issues like the risks of female circumcision and sexually transmitted diseases. In addition to that, a distinguishing factor about Dr. Soh is he is a playwright. And in fact, he was stage production manager for several plays and a lead actor for one of them. Even wrote a play about Carl Jung, which had a 90-person production in 2008. So he has a fairly distinguished and varied background. He's also a trainee at the New Center for Psychoanalysis. So Dr. Soh, one of his interests is in depression and suicide. Pleasure to be able to moderate this. If you have questions along the way, please put them in the Q&A rather than the chat Q&A function, and we'll get to them at the end, but feel free to drop them in whenever you like. And let me turn this over to Dr. Soh.
All right. Yeah, thank you, Dr. Mikulec. Today I'll be talking about depression and suicide in teens. And I guess before I start, I just want to mention that I have no disclosures and that there will be a Q&A session at the end. You can always submit questions to the Q&A, which Dr. Mikulec will moderate. So let me share my screen and we can get started. So this is my presentation. Depression and suicide in teens. I think this is something that has been on my mind for a while. It's actually adapted from a previous presentation that happened right before the pandemic in February. And I presented this Ariadne's Threat and Suicide as a Human Narrative back in February of 2020. And so that was the last time that I kind of was going over this in my mind. And disclaimer, I just want to say that please excuse my beginner's mind. I'm no way or in no manner any expert of the subject matter. It's just that I have great curiosity about it. In fact, probably my present reality is more like this rather than being an expert. I just kind of hobble this together. And my actual reality is probably more like this, where I probably actually don't know what the heck is going on most of the time. So suicide, we all know what suicide is. And, just to kind of define it, it's the act of taking one's own life voluntarily and intentionally. And usually it's preceded by a feeling that there's an insurmountable challenge, real or imagined, that leads to despair, hopelessness, and ultimately the impulsive or planned ending of one's life. And so, there are kind of some trends these days with suicide where, it's the second leading cause of death in the United States for ages 10 to 19. And that's like after like accidents. And kind of the surprising statistic here is that 1 out of every 6 high school students has considered suicide in the past year. I can't really, as I think about my patients, the numerous patients that we see, I wouldn't have imagined it to be like 1 out of every 6 patients that I may encounter. And so that, kind of perhaps some of the reason that I'm trying to, talk about this today and have great curiosity about it, because, we want to just make sure that we don't miss those 1 out of every 6. So trends over time, we've all seen graphs like this. Basically, over here in the 90s, there was kind of a rise, and then in the 2000s, there was a dip. And then as we head into Generation Z, we have kind of a rise again. We're not exactly sure why that is. Some postulate that it could be due to the influence of social media and the hyperconnectedness of the web and the disconnection of kind of real life. I think through my generation, kids were still playing outside, but now everybody's online and at home. So kind of some things to kind of think about. And so, age of most risk peaks at 16 to 18 years old. And this is the highest prevalence rate across like all lifespan. And so this is probably the most vulnerable time point, right when they are kind of developing the front part of their brain where they can plan and act upon their feelings, but at the same time not developed enough to kind of put the brakes on and be like, wait a minute, okay, you know what, maybe this is not worth ending my life over. There are different statistics depending on where you look, but this one from 2003, for every 100 to 200 suicide attempts, there is a youth suicide. So, and the numbers are pretty high. And about 30 to 50% of adolescent suicide attempters will reattempt suicide in like the following 3 months. So high risk population. And I guess kind of the question that kind of came to my mind is, what can we do for our patients who are hospitalized, they emerge from the hospitalization, or they have an attempt, they go to ER, et cetera. And what can we do for them once they emerge from that? One of the things, of course, is rapid intervention after the first attempt, and treatments that target the internal and external conditions contributing to those attempts. Parts of why it happens. Among younger children, attempts are often impulsive. We have this marshmallow test here. I'm not sure if you guys are familiar, but this kid is doing a good job of not being impulsive. He's holding out before eating the marshmallow. And then so among teenagers, again, as that front part of the brain develops, they may be impulsive because they are upset or they're sad or something has happened, but they can also be planned. And that is a scary part of this choice that sometimes is made, where they purposefully choose to end their lives, and as opposed to impulsive, where they're not really thinking about kind of like kind of the timeline exactly. This one, they may do it kind of in secret or in a way that they can kind of more ensure that it is a completed suicide rather than an interrupted attempt. So, we know what suicide is, but how do we approach kids and teenagers in talking about this? And there's so many books, and, it's like finding the right words is not easy to say. And I think part of the challenge is that suicide has many reasons that it occurs. Over the ages, it's been glorified, romanticized, bemoaned, condemned, vilified through the ages. And, here we have like suicide contagion, Romeo and Juliet, like they both commit suicide in the name of love. This girl, it's for 13 Reasons Why, it's because she has like a list of people who've wronged her. Here it's for honor and out of shame and guilt. And then here for religious reasons, we can do all sorts of things. And most concerning, when I see all these different reasons, this is just like a small kind of sample of different reasons that it can be done for, is that it can be shaped to justify and fit any narrative as an acceptable outcome. And as we know, we don't want this to be an acceptable outcome in anybody's mind, and yet here we are. And so known risk factors, I don't need to name these, we know these already, but basically the most pressing one is probably this history of suicide attempts. And I think just the length of time that they've been feeling suicidal and the intensity. Standard things that we tell parents, these are all things that, so I've not mentioned anything new so far. We asked them to take it seriously, not to overreact, to call the hotline and also to transport them to the ER or call 911. And we also kind of let them know that if they ask the kids about suicide or feeling down, it's not going to cause them to be down or suicidal. In fact, probably it's more protective, given that feelings of sadness are so relational. So, we have all, so we know all that, all the stuff that I kind of like brought up before. So what are the studies about adolescent depression and suicide saying now? And, in our psychopharmacology clinic, the papers selected for the depression module are these ones. And these are some pretty important studies. Basically, what we kind of take away from this is that treatment-resistant depression is really hard to treat. Marginalized children have worse depressions. SSRI is better than SNRI. And here, this is an interesting one where they kind of put a head-to-head study with fluoxetine, cognitive behavioral therapy, and fluoxetine, these alone, and placebo, and kind of saw what happened. And the combination was best. This is the TAD study from 2005. And in terms of depression, 71% of the combination of fluoxetine and CBT benefited, 60% for fluoxetine alone, 43% for cognitive behavioral therapy alone, and interestingly, kind of high number, 35% for placebo. So the sugar pill somehow helped with depression. Kind of goes to show that maybe there's something to the face-to-face time with doctors and mental health professionals that is kind of protective against depression. Just the fact of kind of checking in can help. Now with that said, so that's, okay, so that makes sense. And so the logical conclusion I think that a lot of people make is that then it must probably help for suicidality. And in fact, the surprising thing was that it didn't. So 30% of the people at the beginning of this study had suicidal ideation, and 2% had intense suicidal ideation. And improvement was the least for fluoxetine alone, and greatest for a combination of CBT and fluoxetine. But interestingly, fluoxetine alone didn't appear to help increase the protective factor of becoming suicidal. In fact, we have kind of the opposite effect where we now know we have that black box warning where for adolescents, there's that possibility that it may actually increase suicidality. So what the heck is going on there? And, for fluoxetine alone, it didn't necessarily have increase in suicidal ideation, but there were increases in harm-related behavioral events. So fluoxetine was about 12%. Combination of CBT and fluoxetine was 8.4. Cognitive behavioral psychotherapy was 4.5. So it's probably the most least harmful. Placebo 5.4, so a little bit higher, weird. But that kind of goes to show that there was something about CBT that was protective, even for patients who are on fluoxetine. So there's something about this therapy that is really protective in some ways against suicide. So that was kind of the beginning parts of kind of exploring this idea. And more recently, we had these studies, which I'll kind of go into a bit later, but this is a lot of studies about DBT. And some additional stuff that I kind of looked at were these books. They were kind of helpful in helping me conceptualize this talk. And also this paper that Dr. Mikulicz gave me, which really helped kind of form the core of what people kind of tried to do up through 2006. And then I'll explore from 2006 onwards, what people try to do afterwards to kind of figure out this conundrum of like, how do we treat suicidality? Because it is so resistant to so many modalities of therapy as well as medication. So, basically from those papers, the kind of the most important thing that I saw was point prevalence is 25% of adolescents. At any point in time, there's about 25% of adolescents that have some sort of suicide ideation, whether it's passive or active, pretty high number. And, these are the risk factors. Again, we know these, I don't need to go over them. But amongst these, I thought what was kind of interesting was there's intercorrelated health risk behaviors like binge eating, binge drinking, weapon carrying, unprotected sex. Common to these are difficulties. Maybe this is a hint of like why they're struggling is poor parent-child connection, low parent supervision, poor connection between child and school, association with deviant peer group. So again, perhaps then the reason why things like the therapy modality can really help, because in place of the good enough parent, we got a good enough therapist. So again, this is the paper that Dr. Michalowicz gave me, Adolescent Suicide, Suicidal Behavior. So this is up to 2006. And all sorts of approaches were being implemented. It was really interesting to kind of see and try to make sense of the different approaches. So in red are things that were not as helpful. In green were kind of promising in some ways, but then still very flawed. And these were kind of inconclusive. So we kind of got, one of each. And the things in red, what they shared in common were that they were indirect ways of addressing the suicidality and suicidal behavior. The ones in green were more direct by actually talking about the suicide instead of kind of indirectly trying to treat something else and hoping that the suicidality will lift. So like, for instance, treating the depression and thinking that logically depression will lift. But then the thing is that suicide is not logical, so of course it doesn't play by the rules. And so multiple models are trialed. I mean, individual therapy, supportive, psychodynamic, psychoanalytic, et cetera, multifamily skills training group, family therapy, in between telephone consultations, a lot of different things, and a lot of things that I didn't list that I've never heard of. And basically everything in the kitchen sink was tried, which makes me think that there's a lot of truth to the saying that it takes a village to raise a child. After all of this, there was only a few things that kind of helped, and kind of scary, to really think that, us as quote unquote, like all-knowing psychiatrists and clinicians and psychologists, et cetera, that we don't really know how to help these children. And so, going back to that kind of list of red and green, some patterns kind of emerge as guiding principles. So again, the TAD study showed that medications help depression, but not necessarily suicide. Okay. CBT in combination with SSRI is somehow protective of suicidality as compared to fluoxetine alone. Okay, so there's something here. And the indirect methods of addressing suicide do not work, including like manualized CBT in some ways, as opposed to problem-solving CBT, which is more direct, problem-solving of the suicide. And so these are some of the papers that were in the previous page. These showed more promise. And so, the indirect approach, the hypothesis is that helping children with depression with medications will help decrease suicidality. That's logical, but again, suicide is not a logical thing. It does not live in the realm of logic. And so, whoops. And so, what they've actually found is that there's not really a clear correlation. Like multi-center trials actually showed that there was no real response to suicidality. Again, there's actually a black box warning because it kind of did the opposite. Subsequent meta-analyses kind of showed that there is no clear effect on suicidality. I think the minutiae and nuances there, I'm always happy to discuss, but basically no real effect. And so, in adults, we have some studies about lithium, clozapine, things that we don't really want to start on young kids if there's not like a clear benefit. But, I think moreover for teenagers, there's, again, no clear benefit of medication versus placebo for the suicidal thinking. And so, the next thing then is the direct approach. And this is really kind of addressing the suicidal behaviors, these suicidal thoughts, these suicidal actions. There was some promise here. And, through these studies, as opposed to the previous page where it's kind of red and yellow, there's more green here, more promise. And it basically kind of showed that this outpatient problem-solving CBT and DBT models really kind of help target the suicidal behavior and were the most effective in reducing the risk of like future behaviors in individuals identified as high risk. Maybe some less benefit in those low to moderate risk of suicide, but definitely for those that we worry about the most, there was some benefit. And CBT being a modality of kind of linking thoughts, feelings, and behaviors, and DBT adding on to that to then kind of talk about how we interact with others, like emotional regulation, dysregulation, like all those type of strategies are further explored on top of thoughts, feelings, and behaviors. So that was in 2006. And where are we when we were trying everything in the kitchen sink? And what about now? So, more recently, this is from 2017 from our very own Dr. Joanna Sarno. And there were some kind of things that were shown that were promising. This study showed that strengthening kind of the bonds between parent and youth and kind of helping their communication skills. Remember those kids who are binge eating, binge drinking, carrying weapons, having unprotected sex, by kind of increasing the guidance between parent and child, there is some kind of protective factor that where the parents can kind of successfully guide their children through suicidal and self-harm episodes. To kind of go old school, is the containing environment, right? Where we want to kind of be able to digest and then regurgitate for our kids how they can feel about things like unbearable pain and unsolvable problems. And through that process, we're regulating emotions, tolerating distress, building lives that youths want to live. And these are all really positive things, especially for those who are struggling to find reasons to live. Over here, the efficacy of dialectical behavioral therapy. So back in 2006, there were kind of some smaller studies that didn't have enough numbers, and this one, 173. And the result was that it did show some efficacy and support for the idea that we now have a way to kind of more reliably reduce self-harm and suicide attempts in these highly suicidal self-harming adolescents, and showing a lot of promise. And this editorial kind of also explores that as well. And basically it's saying that, it can be an effective therapy. And it says currently DBT appears to be the front runner of psychological therapies for adolescents with self-harm. But the issue is that due to costs and challenges up to accessibility, no country in the world is likely to provide DBT to all families with need. And, that's, I guess, for lack of better words, that kind of sucks. That's both good and bad news. DBT helps, but is in short supply. And, I know from trying to refer people, it's hard to get in. And so what can we do when we have these kids and they're having a tough time and we know that they're at risk? What can we do for those who are not trained in DBT? How can we help them? What are some practical ways? And so, there's two basic strategies, and it really depends on how much time and flexibility we have in our practices. The first is kind of the usual way where we treat distal and proximal factors. This is kind of the indirect way. The second is actually targeted reduction of suicidal behaviors. So that would be an explicit treatment goal. And of course, while we do this, we have to tread carefully, which I'll kind of talk about, as to not re-traumatize the child. The distal and proximal factors. The distal factors are the things we can't really change. This is the realm of regret and things that we wish we had like a time machine for, or different parents or different century or whatever it may be. Past history of suicide attempts, mental disorders, chronic family stress, gender, LGBT identification, race and ethnicity, things that were kind of interesting to me: rapid cultural transition, assimilation, loss of traditional cultural practices for immigrants or displaced people. And even for upward social mobility, I was like, what the heck? So interestingly, so we all know about kind of Native Americans and their kind of increased risk of suicide. But I think one thing that was kind of interesting for me to kind of notice was for Black male adolescents in higher social class, they also have higher suicide rates due to the pressures of assimilation and loss of traditional protective factors. It's kind of speaking perhaps maybe towards the idea of some aspects of intersectionality. But, I think it goes to show that just because you have higher SES doesn't mean that you are protected. In fact, sometimes it can even be a negative factor, and things to kind of watch out for and always ask for and be on the lookout for. Proximal factors. These are the things, these are the things that happen that, in life where we can't control it, causes us pain, and you know, can kind of precipitate some of these suicidal thoughts and depressions. So these are, you know, academic difficulties is a common one, you know, abuse, stressful life events, and things like contagion. And so you know, from these, it's really the combination of this and this that is a big red flag, because that is causing length of time as well as intensity. And so that is much more, that combination is a stronger predictor of suicidal behavior than just maybe a bunch of proximal things at once. I mean, that's definitely stressful, but if there's been something in the past that has kind of primed us towards reacting to this differently, we have to be careful. So explicitly treating suicide, meaning directly talking about it, you know, currently, given that the biggest risk factor for completed suicide is previous suicide attempt, you know, we have to kind of, I think, maybe kind of think about and be thoughtful of how we're trying to treat some of these patients and see them. In patients who are known to be suicidal, one tip that I picked up from Dr. Sarna was that she said to do a PHQ-9 at every visit and ask if this accurately reflects how they are feeling. Because sometimes they just kind of answer matter of fact, and they will admit that this doesn't actually reflect what's going on. And if it doesn't, do it together and try to find out more about why there is a disconnect. There's something going on there. And that will help you to not only get to know the child more, but also build trust and then hopefully more rapport. When there is a contagion going around in the news, be more vigilant, you know, especially for those kids that have kind of more like identity diffusion, and ask about related health factors such as binge eating, binge drinking, weapon carrying, unprotected sex, sleep disturbance. I volunteered at the CBT for insomnia clinic, and you know, the sleep is so connected to mood. And there are people, you know, that really struggle with like their sleep, and as a result can ask themselves, is it even worth like living when everything's so hard? Can't even sleep properly. So things like this can also be linked. And if it contributes to their suicidal ideation, thoughts and feelings, let's try to find ways to maybe reduce these things that are classically not thought about as ways to reduce depressive and suicidal thoughts. You know, and I say this not with any research backing it, but just kind of my own thoughts and observations. Reducing lethal means, of course, and getting patient connected to problem-solving CBT or DBT practitioner. Now, as I said, there's a shortage, and also it's not always easy to get in. So if it's not possible, you know, what can we do? And I think asking about adolescent risk factors and the quality of relationships with self and others can be helpful. And I'll kind of talk about maybe how we can kind of go about that. Unhelpful things, suicide contracts. They lead to deception and resulting feelings of shame and guilt. For those who are chronically suicidal, the unfortunate reality is that it will happen again. And that might kind of lead to a path of them hiding these things. In terms of like reducing lethal means, you know, trying to get parents to get rid of guns, weapons altogether, not helpful, will be met with resistance. Better to use that time to work with them on safety. So that we're on the same page of protecting the child rather than you know, trying to get rid of the weapons that, you know, they may have good reason to have. And so, you know, regarding kind of what we can do, I think practicing applied curiosity, you know, also known as mentalization on these, and talking about these adolescents, about their adolescent stressors, can be a very rich area where we can not only get to know the kid, but again, build trust and really talk about these issues that bring up a lot of stress. Hormones, I mean, like, gosh, just adolescence is so filled with so many changes. There's hormones, sexuality, body image, shifting social milieu, like the philosophical problem of knowledge, the philosophical problem of conductance, Freudian genital stage, losses of love objects of the past, youthful ideals, the endless potential, where everybody can become an astronaut, the battle between the id, ego, superego, Ericksonian identity versus role confusion. You know, this is why suicide contagion happens for those who are kind of role confused, and why people subject themselves, perhaps, this is my own idea, to maybe like the masochistic adulation found like on TikTok, where they love it, but then they also hate it. Individuation, Oedipal complexes, or, sorry, conflicts, Piaget, like, we're exiting concrete operations. We're exiting black and white thinking that is developmentally appropriate and entering abstract thought. And for things that are not practiced, like just becoming new to abstract thought, that can be really tough and very stressful. Good enough mothers, refrigerator mothers, wire monkey mothers, holding environments, Jungian archetypes, to be labeled as one of these and not feel like you're kind of fitting into your own skin, intersectionality, et cetera. So just talking about these things with them, being very curious about their lives, their parents, their school issues, can help them develop a language about their thoughts and feelings. And that is so important. People who have poor language skills are especially vulnerable because they don't know what to do with all this like mixed up feeling inside. They have like this going on inside. This is a gift from Dr. Kataoka and Dr. Richards. And so like if they're feeling like all mixed up inside, it can lead to greater impulsivity and greater ways of hurting themselves. But if they find an easier way by talking about these things and developing that language, it may be easier to not do the extreme thing. And the utility of talking about these things, not only is it, it helps to kind of them organize these different changes within them, but it also helps them to kind of learn how to communicate well about these things to reduce misunderstandings. Because being misunderstood, especially at that age, is one of the most painful things in the world. Always painful, but especially at that age, I would say. As we get older, we accumulate a bunch of misunderstandings. So we have other misunderstandings to kind of reference from and build a book of misunderstandings and kind of are able to navigate. But at that age, man, it feels like the end of the world. With mentalization, why do all this work? Because we want to build trust and, asking them things like, what is your experience? Why did it bother you? Et cetera, like how angry are you right now? Really challenging these patients to elaborate, be descriptive. This causes basic mentalization where, as we're asking these questions, that the kid may be like, hey, why is this person so curious about my emotions? Is there something that I should be curious about myself? They'll start asking themselves this question. This is the internalized therapist. And then from there, it also then gets turned on to the people around them. I wonder what, if I'm feeling this, I wonder if somebody else is feeling something else. And it may help them feel a little bit less alone. In addition to that previous list of all of those things that can happen, we have also some things that are more research-backed where, in DBT, we can also kind of explore the person's emotion regulation, interpersonal effectiveness, distress tolerance, the idea of walking the middle path, or what I like to call the gray area thinking, and core mindfulness. And so, as we talk to these patients, there's some difficulties that are going to emerge, and I think we should be prepared for. This suicidal behavior doesn't emerge out of nowhere. It emerges as a learned method of coping with acute emotional suffering when no other coping options seem possible or are available. And this dysregulation causes extreme dysphoria, anxiety, panic, and it can't be really easily ameliorated, especially if they don't have the skills. And so things that, if things are this terrifying, we will encounter cognitive rigidity. It may be perpetuated by black and white thinking. They may have poor problem solving skills, okay? And so that's why interpersonal effectiveness or kind of problem solving with the kid is really effective. Here with this rigidity, it can kind of walking the middle path, talking about gray area thinking can kind of help loosen some of these things. There's also like these other things as well, like passive styles of personality, hopelessness, feeling like nothing's ever going to get better, et cetera, et cetera. And, just kind of to point out some differences between children and adolescents, older kids, what makes them kind of riskier is that they have more time to develop mood disorders, get involved in substances, have more of a tumultuous relationship with parents, are also more cognitively capable of planning and executing lethal suicide attempt. In speaking to that, the precocious youths are often overrepresented in younger suicide victims. They are usually able to, again, plan with that forebrain that is developing, and they're kind of making use of it in that way. This autonomy is a double-edged sword. Social support from parents And again, we need a village to raise a child, but in the modern age where we don't really know our neighbors, sometimes a parent needs a village, so it's much easier to become disconnected. Caveats, as I mentioned before, the suicidality can be linked to trauma. And so I think, again, having a very curious approach where we are asking questions, but not too invasive, and also not being judgmental and being open-minded as we talk to these kids is really important, because we can't ask these kids to change too quickly. This is a developed, learned method of coping. We can't take away their coping too quickly, otherwise it'll be too overwhelming for them. And also, we can't just drop it altogether. That will lead to further hopelessness, feeling ignored for those who are already self-critical. And so a consistent, curious, mentalizing approach may work best with, again, depending on your practice, PHQ diet at regular visit intervals, and trying to really find out why things go up and down, or why things are kind of remaining the same despite differences in presentation. And we really should try to understand the patient's self-construct. And so for us, the task at hand is really to both help hold the acceptance, the idea of being kind to ourselves, to not being too judgmental or critical of ourselves, but also to realize that there can be some changes simultaneously that can help us. Being able to temporarily tolerate this pain is an important step into understanding the suffering and one's role of how to reduce it. There's pain, there's suffering. How can we reduce the suffering from the inevitable pains in life? So, I think ideas expanding, this kind of came up over the past few years. And I kind of wanted to share some ideas. I'm open for discussion, but these are some things that I thought could help. Given that I'm not a DBT therapist, I would love to be trained as one. But again, given my limited repertoire, I kind of thinking about what we can do as clinicians who are not trained. And so, for younger children, we can start by practicing emotion regulation. We do this by feelings thermometers, red feelings, orange feelings, green feelings, not labeling them as negative or bad feelings, talking about uncomfortable feelings, comfortable feelings, distress tolerance. We can kind of do these fun exercises with kids to then help them feel more in control and have mastery. And for teenagers, on top of emotion regulation and distress tolerance, which are the previous two slides, they can also learn about walking the middle path, this gray area thinking, practicing core mindfulness, and buffering themselves with interpersonal effectiveness, things that will require a bit more maturity, I would say. And one of the ways that explore the parallels to emotion regulation and all those skills is for them to consider the idea of their narrative. Like what story are they telling themselves that is kind of causing this climax of suicidality and this resolution where we're having unwanted kind of outcomes and ends to our stories? And is there a way that, despite the inevitable rising action, is there a way to try to change this story? And so I kind of rely on the ancient wisdom of the dramatic structure. This is a structure of storytelling that has been around for thousands of years. And, with this in mind, I ask, what is going on in their lives, and listen to the story of their own development, their exposition, to get an idea of the subtext of their stressors, the rising action that led them to becoming suicidal, the climax. And ultimately, what we want is safety in their following action and the resolution. We want them to go here and not so much over here. And to do this is to kind of help them kind of mentalize and understand themselves. Now, with that said, I was talking about overwhelming earlier, and what we may be asking them to do is traverse this huge journey, and that is not always possible. Piaget talks about this idea of the zone of proximal development, and what we might be asking them to do is that, to try to go there. And they're finding that even with parents' help, teachers' help, everybody's help, that they can't do it because we're maybe asking too much. And it's maybe how we can kind of get to end of the line thinking, because they're feeling that they can't even do this if it's guided. So how are they supposed to grow up and become adults if they can't do this now? And it's important, again, then to remember to think of how to maybe chunk this into zones of proximal development, smaller goals that are easier to kind of navigate. We need the parent next to us. We need the training wheels to then be able to ride the bike on our own. If we were to just ride on the bike and be push down the mountain or push down the hill, and then asked to be able to ride the bike, I think the kid would most likely just give up after a bunch of bangs to the head and scrapes and bruises. They're just going to give up altogether. So we need these supports. We need to kind of think about the zone of proximal development. Can't do this now, can't do it with help, can do now. We want to expand this in ways that we can, and I think that's why therapy helps in all the previous studies. And I kind of also link this to the greater narrative of humankind. This idea of becoming stuck in this kind of zone of proximal development. It's not, here and here. I just kind of think that this is kind of no coincidence. Like, it's harder to leave as we get out. This is the story of Ariadne's thread and Theseus and the Minotaur. The Minotaur is at the center of the maze. The hero Theseus has to come in and destroy it, but then he knows that other heroes have not been able to emerge after this because they can't find their way out from this cavernous maze. And Ariadne, being the guide and being the helper, gives him this golden thread that allows him to get in and allows him to get out successfully, defeating his foe, a physical foe, concrete foe, but really representing the battles that we have within. In more modern times, hey, it's the same language here. Leonardo DiCaprio, his wife incidentally committed suicide in this story, and he's battling with his own Maul. That's the character's name, her own Minotaur, and then not by coincidence, the character who is making the mazes, her name is Ariadne, and she's the one who kind of guides him out of that trap. These stories are universal, dramatic fairy tales, Hansel and Gretel, the idea of kind of leaving bed trail and kind of having another Ariadne of sorts to kind of guide them back. And so this leads to the idea of kind of core mindfulness. Like, if we're able to kind of keep these things in mind, observe without judging, describing facts, participating in a discussion about what's going on within them, then they can benefit. And, I kind of think of us as weavers of this golden thread. I kind of made it in the shape of this dramatic structure because I think within the thread, as we kind of weave the thread, we are kind of creating a story for these kids and perhaps trying to weave it in a different way where the kind of steps take on different significance. And it's kind of like a thread of proximal development. We're kind of, little by little, kind of like Hansel and Gretel, just like step by step, we're just kind of leaving out a little bit of string, leaving out a little bit of stone, leaving out a little bit of bread for us to be able to traverse our way back out from this terrifying Minotaur back to the real world, rather than the imagined fears and the real or imagined that lurk within the depths of these mazes that we may be thrown into or create for ourselves. So, with that, I like to do like a little bit to drive home the point. I like to do a little bit of like emotion education about, and also kind of talk about how to regulate these emotions. I really like this movie, Inside Out. I know not everybody's a fan, but I think it was kind of a good introduction for kids to kind of conceptualize that these other emotions, sadness, fear, disgust, anger, are not bad emotions. And I kind of draw a simplified thing for kids and as well as teenagers to kind of talk about the different roles of emotion. And I'm kind of gonna just skip through this, but basically, this is protective emotions that help kind of direct us to our future. And these are kind of one step too far, one step too far, one step too far, one step too far, where they're maladaptive. And I share this with parents if their kid is either manic or if they have schizophrenia or some sort of psychosis, or sometimes even with like an eating disorder. I kind of talk about delusional thinking. But anyway, I don't really talk about this with kids. But then I talk about like the relation that of worry being protected to the future, sadness being protected for the past, how it helps us process sad events that are inevitable so that we can move forward thinking about these things in a more positive way. Worry protecting us for the future, where if we weren't worried, we wouldn't do our homework, we wouldn't listen to like get up on time for work, et cetera, and how these things can kind of spiral out and then become anxiety and depression, where anxiety prevents us from doing the things that we want. So that leads into the realm of regret. And then regret informs our future of things that we don't want to happen, which creates anxiety and it spirals out. So like the question is, then how do we kind of come in? And, the goal is to come in. Again, I'm going to kind of rush through this, but basically medications can kind of bring us here. And I really think it's the role of therapy to kind of bring these nidices that bring us out here in the first place to kind of drive home the point. So again, things like DBT, therapy, et cetera. Again, this is what we don't want. And again, some kind of goofy parallels between how this might feel like inside and how this is kind of one of the oldest stories told and written and recorded, Theseus and Ariadne's thread. It's not too different from the schema of development, no matter which branch you subscribe to. This is Erikson, Maslow, Piaget. And I really like Piaget because I guess I like graphs and I like his thinking behind it. With 7 to 11-year-olds with concrete operations, they're very black and white simply. And starting here, we can kind of they enter formal operations so they can think abstractly and thereby enter the middle path or the gray area. And so I like to explore with things that kids know, things in popular media about black and white thinking, so that they feel that they have mastery and control over the knowledge that they already know very well. People, kids often watch these movies over and over. I also use other things that kids like, but I like to use this one just because this was one of my favorite movies as a kid. And kids these days continue to watch it. I guess the parents are kind of revisiting their favorites. So the good characters are obviously handsome. They look very nice. Bad characters look evil. His name is Scar. He literally has a scar on his face. Like this is drawn this way for Disney movies because kids understand the world in very black and white terms. And interestingly, the green here is about full of life. It's trees, and over here it's like full of death. It's like geyser steam. And to drive home the point, in case it was like not subtle, not in your face enough, there's no subtlety here. There's like he is evil. Like I mean, come on, like this is like just a few lines removed from like this over here. So and even the CGI counterpart, with supposed to be more realistic, Scar looks like a angry, like mean, nasty lion. Handsome. So, so kids, they will then recognize, I asked them like, hey, do you watch like the Discovery Channel? Do you watch nature shows? They'll recognize this. And the conflict happens where we want this to be the reality. We want this white area to be the reality. We want everybody to get along, but then this happens. And who do you root for? Do you root for this guy, the giraffe, or do you root for Simba? And this is the kind of conflict where we can kind of get stuck and develop ambivalence over. And so, I think it's really important to then normalize black and white thinking and kind of talk about how it can lead to suicidal thinking. And at this point, kids become usually kind of curious, teenagers, about what other options are there besides black and white. And, I use like these gray area characters that we're not sure if they're good or bad to kind of drive home the point that with their ability to kind of do abstract thinking, that there are areas in between that are neither good or bad. And then they can then think about themselves in that way as well. Like, I'm not good, I'm not bad. There's something in between that's happening. This is normal. Oops. And so, younger kids here, then as we develop emotional granularity, we're here, teenagers, as adults, hopefully we can do this without getting too dysregulated. I mean, this is pretty dysregulating, but we make it through, right? And ages 0 to 10, this is developing normal concrete operations. We start entering formal in the middle, at the end. Hopefully the goal is to get here. And I like to conceptualize it as age 20 is 0% adult, 0% kid, age 10 is 0% adult, 100% kid. And we're kind of creating a gradient here. And it also gives them something to look forward to. Speaking the dramatic narrative, or the dramatic structure, it gives them the hope that things will get better. Again, this is another strategy that I use with parents who are also kind of at wit's end. So, now that we have these ideas in place, how do we use this to decrease suicidal thinking, increase interpersonal effectiveness? I sometimes ask, given everything that you've told me, I wonder if there's been several unfair things in your life. The answer is always yes. And I bring up the idea of a car salesman because the kids naturally know that you're not supposed to fight with them. And if you really want the car, you're not going to just run away, and that they have to negotiate. It's never failed me. And they answer that you negotiate or you talk with them, or sometimes they see you verbally yell at them or fight with them, but then it's always a type of conversation. And then you get the car that you want. And so we generalize this skill. And then they recognize after some prodding and some kind of open-ended questioning that, if they're in situations that lead to fight or flight, neither of us that make us happy, and they're kind of stuck in concrete operations, they can move into abstract thinking. We can kind of bump them along by then exploring the idea that some of these things can be negotiated, talked through, and perhaps a different outcome can happen other than the ones that are part of our narrative, and they feel like it'll always be that way, but maybe not. We all have like bullies that become friends, right? Or we ourselves were bullies and we became friends. And so this is why I really emphasize that talking to a therapist or psychiatrist is an emotional negotiation of sorts to reduce those unfair feelings and make life feel more fair, even if the thing that's unfair is still continuing. And normalize, I love, movies about teenagers just because they're so funny. And there's always like a scene at like lunch, at the lunch tables where like they don't know where they fit in. They're always the same, but then they're always fun. And normalize this, you're not alone. And then by recognizing that they're not alone, they are kind of more equipped to perhaps kind of get to this outcome rather than having this very isolated outcome where they are kind of thinking about this. And so, I think as mental health providers, we take on many roles. And based on the latest research on adolescent suicide, Mueller wants to consider maybe teachers of emotional and behavioral regulation, practitioners of core mindfulness, negotiators of interpersonal effectiveness, and walkers of the gray middle path. These are roles to consider as we help our teens and children regain their footing through their personal mazes. Harlow's monkey, we can maybe guide them hand in hand out from kind of the misery that they might be in. And I think because in the end, whether they are new to this or have been on this path before, I truly believe that those who are struggling all deserve a fighting chance to emerge victorious from the minotaurs, the beasts that ail them. And to make that journey and to come back, they will require guides. They need their Ariadne to kind of lay down the string. Whoops, sorry, sensitive mouse. And they need these Ariadnes of their own. For those who are fortunate, they have parents, they have grandparents, they have special teachers or special people in their lives. Not everybody has that fortunate outcome of being kind of brought into that. And so it kind of falls upon us to maybe pick up that string and proximally feel the path before them, to venture forth and travel with them hand in hand through unsolvable, unbearable, unlivable pain and suffering and events. And I truly think that, given the shortage of people, there's already not enough child analysis psychiatrists, psychologists. I think we really have to pick up that mantle. And so just some quotes to kind of end our time with. I really like these quotes by the very quotable C.S. Lewis. Someday you'll be old enough to start reading fairy tales again. And I always remind myself, the pain I feel now is the happiness I had before. That's the deal. Thank you very much. I just want to thank everybody, faculty, teachers, fellows, people I work with, people who support me from behind the scenes, especially families and patients who have really helped in the process of shaping who I am today and who we are today. It takes a village to raise a child, and I think also a child psychiatrist as well. Thank you.
Thanks very much, Dr. Soh. That was a wonderful talk, very comprehensive. I like the way you mix research with media, with clinical suggestions and strategies. Very nicely done. We have a number of questions, but only about 5 minutes, so I'm going to go quickly. First, could you comment a little bit on the role of social media in suicidality? The common belief is that TikTok is encouraging more suicides, or as other people are saying, TikTok is supportive of people who are suicidal. What's your take on it?
I think for certain pockets it can be very supportive for people, and then other pockets where it can be very harmful. And I think sometimes what can happen is that, like, let's say a video goes viral or something happens, and they may have had a community before where they, a smaller community where they fit in, and especially for people who are kind of on the margins of like different intersectionalities, et cetera, they may suddenly find themselves under a different type of scrutiny from like online trolls, and then really struggle with the loss of community. And I think that's one thing that can be really detrimental. Also, people, instead of connecting in person, they are connecting through this kind of artificial medium that is designed by adults. very binary. Either you like or you don't like, and then and it can kind of create a different way to especially at that age with identity confusion. Things can get even more confusing. I mean, I don't have any social media. I mean, it's just too much, even for me as an adult. Hopefully that answers your question.
You have. This one's from Mike Strober, and I think I will answer it, put the question up live. Excellent presentation. It's worth noting the two deep analyses of all random control studies of antidepressants, most involving SSRIs in children and adolescents. Roughly 2,100 participants randomized to active drug and an equal number to placebo, but no suicide occurred and there were no near fatal attempts. There's references to wanting to be dead and low morbidity behavior with scratching, skin cutting that separated drug from placebo. Importantly, in the years after the black box warning, the number of prescriptions for antidepressants in the pediatric age group drastically decreased, associated with a correspondingly increased rate of suicide. Do you want to comment on that at all?
Yeah, thank you for kind of adding to that. Yeah, I think the research is like all over the place. There's some that show that like with placebo, there's like a 0.2% increase of suicidal ideation and rate as opposed to SSRI, which is like 0.3%. Kind of interesting that even the sugar pill causes something to happen. I don't know. I'm not an expert. I'm just very curious about it. I hope that answers as much as I think that's the extent that I can talk about it.
For Dr. McCracken. Thanks, Hendrick. Tons to think about. A question is, I'm a little confused about your immediate recommendations for a child with suicidal ideation. You seem to recommend with evidence a direct approach like CBT, DBT, or family, but also advise less directed approaches such as mentalization. Can you help me appreciate the best first steps?
Yeah, I think so. Thank you for that question. I think with the direct approaches, I'm not trained in CBT. Sorry, not trained in DBT, and there is a chance that even with therapy, there is a chance of doing more harm than good. And so I was just trying to think of ways that we can help support the patients. And I think mentalization is really excellent for just kind of helping to support the kid, get to know them, build trust. If there is something in their past, like abuse or something traumatic that has happened, or whether it's a distal or proximal factor, if we get to know them and understand the risk factors by getting to know them in that way, by asking questions, being deeply curious, by being not judgmental, we may then be able to at least catch them earlier, perhaps. That's an excellent point. It's not a way to treat them, but perhaps to identify them and also recognize that there is a need, and maybe then do more often PHQ-9s every time we meet. Yeah. It's really, really tough. But I'm thankful to the people who are doing the research, because it's not easy research to do, not an easy population to treat. I mean, so many studies actually exclude suicidal patients. So it's a great disservice.
So what are your plans for next year?
For me, I am going to continue to work at the Koreatown Youth Clinic. A lot of the kids' parents don't speak English, or they're immigrants, or the kids themselves don't speak English. And my heart really goes out to them. I think just because you're born into that doesn't mean that you should get subpar care or no care at all. I think before I joined, they didn't have a psychiatrist for like 5 months. So they're like getting their care in like emergency rooms, and terrible, like long waits, parents who are working and trying to like get to and from work, like have to interrupt that, losing income, losing productivity. Anyway, I can go on and on. I'm also going to start private practice. I'm very interested in therapy, so I'm going to try to continue to learn these skills. I hope and aspire to get better at a variety of therapies. And then I'll also, I might be doing some additional telehealth, since we've built up the skills over this past year anyway.
By hook or by crook. Yeah. Okay. Well, thank you very much, Hendrick. Excellent presentation. Good luck in everything you do in the future. Thank you, everybody.
Thank you very much. Thank you, everybody. Bye.